Okay, we're going to talk about understanding the mechanism of action of the mini-gastric bypass. It's important to emphasize that we'll be talking about the mini-gastric bypass, and that's not the so-called single anastomosis bypass, and it's critical that people understand that there are a variety of misnomers, people claiming to do what they call a mini-gastric bypass that's not a mini-gastric bypass, and then doing other operations that are single anastomosis and assuming it's the same as the mini-gastric bypass. And all of these errors in naming demonstrates the widespread misunderstanding of the mini-gastric bypass itself. And we're going to try and deal with these dual problems during this description. The mini-gastric bypass, since it was first presented at the ASBS meeting in 2000, American surgeons rose by the dozens to criticize Dr. Rutledge and his presentation of the mini-gastric bypass. Subsequent to that presentation, Dr. Rutledge received criticism for a variety of issues, including the fact that the laparoscopic technique did not include removal of the gallbladder, the fact that it was not retrocolic and retrogastric, which was at the time felt to be a standard for the Roux-en-Y gastric bypass. Widespread confusion that continues to this day, confusing the mini-gastric bypass with the old Mason loop gastric bypass. And there was widespread confusion and conclusions that all mini-gastric bypass patients would suffer from the bile reflux esophagitis that had led to the abandonment of the old Mason loop. There was also widespread misunderstanding of the medical literature, conclusion that the Billroth-2 caused significant bile reflux gastritis, and this led progressively to an increased risk of gastric cancer, which has now clearly been shown to be incorrect. There was a widespread opinion that the gastric pouch and the gastric jejunostomy were too big. The gastric pouch and the gastric jejunostomy did not match the standards of the time for the Roux-en-Y gastric bypass. In addition, Dr. Rutledge was criticized for using email and having a website. Now, almost 20 years after the first mini-gastric bypass has been performed, we know a lot of these criticisms are and have been shown to be wrong. It is not true that the mini-gastric bypass is exactly and precisely the same as a Roux-en-Y with just one less anastomosis. This confusion led to the naming of the mini-gastric bypass as the so-called one anastomosis bypass. You cannot understand the anatomy of the MGB and its surgical technique unless you understand the mechanism of action. And many of these understandings are based on important historical, general surgical history. What we find is in bariatric surgeons around the world today is many of these principles that have been shown from 50 to 100 years ago have been forgotten. And they lead to misunderstandings and confusion, such that many people for the past 20 years continue to confuse the mini-gastric bypass with the old Mason loop bypass. This and many other confusions, errors, mistakes in understanding will be addressed in this chapter. It's wrong to think of the mini-gastric bypass as just a Roux-en-Y bypass with one less anastomosis. This erroneous thinking has led to renaming the mini-gastric bypass as the single anastomosis bypass, as if this were the critical factor in describing the operation. So we're going to take some time in the discussion of this chapter to explain the misunderstanding that the MGB and the Roux-en-Y are not the same thing. The MGB is not the Roux-en-Y with one less anastomosis. In summary of what we'll be describing in this chapter are dog and human studies which demonstrate the differences and advantages of the mini-gastric bypass. Specifically, the mini-gastric bypass is non-obstructive restriction. Let Let me repeat that because we find many people get confused about this. The mini-gastric bypass restricts the intake of food by about 75% in our surveys without obstruction. So there is a decrease in food intake without the blockage, the obstruction, the stricture that's created in the lap band, the sleeve, and the Roux-en-Y. The biliopancreatic limb length is the best length. That is to say, it's both longer than the Roux-en-Y bypass, longer than the biliopancreatic limb of the Roux-en-Y, and shorter than the limb of the biliopancreatic diversion. So let's say that again. The Roux-en-Y bypass has a shorter biliopancreatic limb. And the biliopancreatic bypass, or the duodenal switch, or the SATI, or its ilk, have a much longer biliopancreatic limb. And we'll talk about all of these things. The biliopancreatic limb in the MGB, ranging around 2 meters, 1.5 to 2 meters, seems to result in an ideal amount of weight loss and fatty food intolerance while limiting the side effects of malnutrition, micronutrient, and vitamin deficiencies. In addition, a critical component of the operation that is misunderstood by Roux-en-Y surgeons when they adopt the mini-gastric bypass is the Billroth-2 gastrojejunostomy is a wide anastomosis. We'll talk about general surgery, studies in both animals and human beings demonstrating that the large pouch compared to the Roux-en-Y and the sleeve and the band, as well as the wide open anastomosis, is one of the critical factors for the effectiveness of the mini-gastric bypass. All of these things may sound difficult to understand or even wrong to the knowledgeable bariatric surgeon in 2017. We will show in the rest of this chapter are dozens of studies in both general surgery and animal studies which confirm these findings and demonstrate that the effectiveness of the MGB that outstrips the band, the sleeve, and the Roux-en-Y is based upon creating an MGB which utilizes these critical factors. And if the surgeon and the patient misunderstand these things, the outcome will be hampered and complications, problems, and difficulties can occur. And we'll demonstrate and talk about some of these examples where errors in understanding have led to bad outcomes. In short, the goal of this chapter is to explain one simple concept. Unless you understand the mini-gastric bypass mechanism of action, not do the MGB correctly. Doing the MGB right demands that you understand the principles that underline the MGB's creation, both anatomic and physiologic. In short, the MGB induces the well-known, widely described, and well-understood post-gastrectomy syndrome. MGB patients can eat. They do not have a stricture, obstruction, or blockage as the lap band, the sleeve, and the Roux-en-Y are designed to create. But instead, the MGB patients can eat, but they cannot eat sweets, liquid calories, junk food, or fatty foods simply because of the creation of a post-gastrectomy syndrome situation. This leads to a post-gastrectomy syndrome diet, which is, as the educated general surgeon will know, 6 small feedings, avoiding sweets, junk foods, and fatty foods, and eating a high bulk diet with 6 small feedings, large amounts of fresh fruits and vegetables as a percentage, but small meals 6 times a day. And this is an entirely healthy diet. It's one that matches closely to the Mediterranean diet, which many studies have suggested may be the most healthy diet for human beings. So for all these reasons, the MGB is a success. It leads to success for the patients. And because it is so different from present understanding in bariatric surgery, this chapter is critical for doing the MGB right. Period. Paragraph. Before we get into a further discussion, one might raise the question, well, why not just keep doing the, quote, gold standard, the Roux-en-Y gastric bypass? Why even bring up the MGB? Why discuss it? Why bring up that operation in particular when they are both bypasses and the Roux-en-Y has a test of time? So we'll discuss that in the introduction to this chapter because it's critical for understanding why we want to go further in this discussion. And we'll end part 1 here at slide 10.